Hello, everyone. You are welcome to my YouTube channel. The topic of discussion is lymphatic filariasis. What is lymphatic filariasis? It's a neglected tropical disease caused by filaria worms known as Wuchereria bancrofti, Brucia malai, or Brucia timori. These thread-like adult parasites live in lymphatic channels or lymph nodes, where they remain viable for more than 2 decades. Lymphatic filariasis is transmitted to humans by a bite of a female Anopheles Aedes or Culex mosquito. The microfilaria they produce exhibit nocturnal periodicity, that is, they can be seen in the peripheral blood at night between 10 p.m. and 2 a.m. This to coincide with the time of biting by the female mosquito. Here is the life cycle of Wuchereria bancrofti. All the filaria worms have similar life cycle, starting with an infected human host. Here you have the adult worms in the lymphatics. The adult female worm produces sheeted microfilariae that migrate to the lymph and blood channels. And then, following the bite of the female mosquito, in order to obtain a blood meal, the microfilariae are picked up, they are ingested, and immediately the microfilariae sheds off the sheets, much like taking off its coat, and then penetrate the mosquito's midgut, where they migrate to the thoracic muscles, and they become first-stage larvae, known as L1 larvae. They molt twice, and they become the third-stage larvae, also known as L3. These are the infective larvae. That is, the third stage larvae is the infective stage of the filaria worm. The infective stage then migrates to the head and proboscis of the mosquito, and then they are ready to be transmitted to another human host following the bite of the female mosquito. What is the epidemiology of lymphatic filariasis? Wuchereria bancrofti is the most widely distributed human filaria parasite. Humans are the only definitive host for the parasite. Over 856 million people are at risk of contracting lymphatic filariasis, and it is found throughout the tropics and subtropics, including Asia and the Pacific Island, Africa, areas of South America and Caribbean basin. There are two types or two periodic forms. You have the nocturnally periodic forms and the subperiodic form. The nocturnally periodic forms of microfilaria are scarce. They are not found in the peripheral blood by day, but increase at night, whereas the subperiodic forms are present in peripheral blood at all times and reach maximal levels in the afternoon. The natural vectors for Wuchereria bancrofti are Culex fatigans mosquitoes, which can be found in urban settings, and Anopheles or Aedean mosquitoes in rural areas. What are the clinical manifestations or features of lymphatic filariasis? Both the living and dead adult worms are responsible for the filarial symptoms. There are 3 stages in the clinical manifestations of lymphatic filariasis. First of all, you have the asymptomatic filariasis, where there are no symptoms as such. Infected children in endemic areas are known to exhibit microfilaria in their blood without symptoms. However, they show moderate lymphadenitis on physical examination. Next stage is the inflammatory filariasis, where the human host responds by allergic reaction to the products produced by or released by both the living and dead adult worms. The symptoms of inflammatory filariasis include epididymitis, which is the inflammation of the epididymis, orchitis, that is the inflammation of the testicles, lymphadenitis, inflammation of the lymph nodes, lymphangitis of the extremities, which is the inflammation of the lymphatic vessels. The lymphatics of the legs and the genitalia are mostly affected. In males, there is acute folliculitis, that is inflammation of the spermatic cord, orchitis, and scrotal edema. These are the main symptoms, while in the females, enlarged mammary glands can be seen. The affected anatomic sites become hot, red, and painful. These are symptoms of inflammation. These inflammatory processes are believed to cause the granulomatous and proliferative processes that precede total lymphatic obstruction. Obstructive filariasis develops usually over years of continuous filarial infections. Eventually, elephantiasis is the outcome of filariasis. Pyroluria is the main symptom of obstructive filariasis. The presence of the adult worm causes lymphatic blockage and lymphedema, which sometimes leads to elephantiasis. Once elephantiasis has developed, the prognosis is poor. Here is a diagram showing the progression in the clinical manifestation of lymphatic filariasis. First of all, you have the asymptomatic filariasis, where microfilaria can be seen in children in endemic areas with headache, nausea, and urticaria, followed by inflammatory filariasis, where the human host is sensitive to the products of both the dead and the living filarial worms: orchitis, epididymitis, folliculitis, lymphadenitis, lymphangitis, scrotal edema, fever, and vomiting. It progresses further into the chronic filariasis, where you have lymphatic dilatation and thickening of vessel walls, lymphedema, chronic status changes, pyroluria, hydrocele, and elephantiasis. Here is a picture of lymphatic filariasis, which is a disease that impairs the function of the lymphatic vessels. Lymphatic filariasis has been eliminated as a public health problem in more than 10 countries. Laboratory diagnosis of lymphatic filariasis. Definitive diagnosis can be made only by detection of the parasite. Microfilaria can be found in the blood, in the hydrocele fluid, or occasionally in other body fluids. Such fluids can be examined microscopically following the concentration of the parasite by the passage of fluid through a polycarbonate cylindrical pore filter with pore size of 3 micrometer, or the centrifugation of fluid fixed in 2% formalin. This is the NOT concentration technique. The timing of blood collection is critical and should be based on the periodicity of the microfilariae in the endemic region involved. Blood film examination after staining by Gemsa or Leishman stain will help to detect the microfilariae. The film or the smear should be prepared at night. Intradermal tests using dirophilaria antigen can also be used. Complement fixation tests. Other tests involve hemagglutination and flocculation tests. Assays for circulating antigens of Wuchereria bancrofti permit the diagnosis of microfilariamic and cryptic amicrofilariamic infection. Two tests are commercially available. One is an enzyme-linked immunosorbent assay, and the other a rapid format immunochromatographic card test. Eosinophilia and elevated serum concentrations of IgE support the diagnosis of lymphatic filariasis. Also, polymerase chain reaction-based assays for detection of DNA of Wuchereria bancrofti and Brugia malai in blood have been developed. Prevention and control of lymphatic filariasis, control of mosquito population and human sources of infection. Diethyl carbamazine is the drug of choice given orally. The massive edema that precedes and accompanies the elephantiasis of the legs can be elevated by use of pressure bandage. Administration of steroids to patients with elephantiasis may be followed by an increased number of microfilariae in the peripheral circulation. Here you have links for further reading. Thank you for watching and listening.